As someone who's applied for these grants, who's seen how competitive they can be, there to echo, Kylie was talking about in terms of like, you have to like painstakingly detail what you're doing, right? You have to show that not only are you just like proposing an idea. Oh, really? A little closer? Okay. You have to demonstrate exactly what you're going to be doing and very specific, like aims and objectives. You have to show how you're going to do it. You have to show all the background work that you've done to get to that point. And then what is going to be the end point, right? Like what are you going to show at the end of that funded period, in addition to those progress reports, to say, hey, like this is how I used that funding. And I think also to the point, like, where some diseases are funded maybe a little bit more than others, I obviously it turns into like a little bit of like, well, they get too much, we get too little. I think obviously we all want people to be healthy, but I think what that ends up doing, right, is like, you might have three fantastic ideas, but you can only fund one, right? And maybe in breast cancer, they can fund two of them or three of them, or maybe they can fund something that's, in addition to something like a core scientific proposal, something that's related to quality of life or toxicity management, things like that. And so I think, like Kylie was saying, I mean, it all, I think, pays huge dividends. And even if that progress, sometimes these things don't pan out, right? Like the results of whatever we think is going to work don't work. But that's still informative, right? That tells us, okay, this approach is not going to be what we should be spending more time on. We're going to switch tacks and try something else. I also, very long time ago, as a high school senior, interned in Capitol Hill. And like I saw kind of how it works, right? Like, yeah, there's like kids, right, like who are doing a lot of these things, not necessarily high schoolers, but like people right out of college, and they don't know a lot, and you can educate them, and then they are not the ones who are ultimately making decisions, but they're in those offices, and cumulatively those decisions are being made. And so I think it makes a big difference. And then the last thing I'll say in terms of the, patient advocates and reviewers is it's so, hugely important. I mean, I think obviously we all try to keep center of mind that, why we're doing this and what the ultimate objective is, but to have someone who's directly impacted, living through it, making sure that we are prioritizing the right things, making sure that we're keeping in mind certain things that might be a little bit far for us. It makes all of the work being done even more important, and more helpful, right, and more applicable. So anyway, that's segue. So I earlier we were talking about a lot of the therapies that we use once a metastasis has been found or disease has recurred. A lot of the work that's being done is in that area appropriately. But as in most cancers, right, we have this idea, which does, I think, hold true for this disease as well, which is, if we can do a better job when the cancer is localized, when the cancer has not spread, perhaps that might be the most impactful time for us to then reduce the need, right, for those additional therapies down the line. And so this, opens up this question of what we call adjuvant therapies, and to an extent, neoadjuvant therapies. And so just before I start, I guess I'll help define that, which is, when someone goes through what we hope is a curative intent, surgery, radiation therapy, intervention of some kind, we know that for depending on the cancer, that might be really effective, it might be partially effective, but some people will have a recurrence. And so when we give treatment at that point, after that initial intervention, we call it adjuvant, right? So it's meant to try to improve the likelihood that curative intent treatment will actually be curative. And so whether it's, someone who has colon cancer, who has surgery to remove their colon, or a lumpectomy for breast cancer, or plaque radiotherapy, whatever treatment comes after that would be adjuvant. And then neoadjuvant care or treatment is when we potentially use some sort of treatment before that, again, with the same objective, trying to make it more effective. So I'm mostly going to talk about adjuvant therapies here, with maybe just a little bit of segue into neoadjuvant. So again, my disclosures and then this background slide, which I won't belabor. So, before I go further, I don't want to spend too much time talking about, biology and things, but I do think that this is a little bit helpful to talk about how we understand this disease, and then that segues into how we think about what effective treatments might be overall, but also in the adjuvant setting, right? And so this diagram is showing how we kind of understand how these tumors develop, right? And so we've got these melanocytes in our eye, and they're sitting there, they're fine. And then in some people, right, there are these foundational, what we call mutations that occur that turn them into like a precursor cancer cell. And I was alluding a bit in terms of the ctDNA that there are certain mutations that we can look for that are very commonly seen across all cancer, across all uveal melanomas. And that's where this, first initiating event, what we call, happens, where there are these mutations in these handful of genes that then turn that normal behaving melanocyte into one that is now not so normal. It is much more likely to turn into a cancer. But then that's not enough, right? That is an initiating event, but that alone does not then cause these cells to start growing and to behaving abnormally. There have to be these additional mutations or events that occur that we think then drive. And depending on those subsequent events, that also seems to dictate the behavior generally. So this figure kind of shows from your left to right that, depending on the changes that we see, whether they are specific mutations, whether they are changes within the chromosomes, or a confluence of different factors, it leads to a different appearing tumor. And also then that does help us understand how that tumor might behave. And so this figure also kind of shows how there was this large project to kind of identify the different genes that we see. And this was called the TCGA, the Cancer Genome Atlas. And so they did this across many different types of cancers. And they subdivided uveal melanoma or ocular melanoma into these 4 types. So I won't go beyond that, but I think that is important because it helps us try to understand, well, who are the people who we really need to try to give these adjuvant therapies to, right? I think before Dr. Singh was talking about how he would approach radiographic surveillance for people depending on their risk factors. And that directly ties into the risk of a recurrence, but that now taking that to the next step, that also then translates into, well, who would benefit the most from some sort of treatment, some sort of intervention at the time around the plaque radiotherapy or the surgery to then hopefully improve things long term. And so there's a whole host of factors that we can think about and that we approach it with. So this table on the left shows something called the AJCC. This is a standard organization that applies staging criteria for all types of cancers. And that's looking at things like size and thickness and extent of where the tumor is going in the eye. And that is generally helpful in terms of our understanding. And then, as I was mentioning, there's some chromosomal changes that we can look at. And then there's specific genetic profile tests like the Castle test. And so all of those things help us together kind of incorporate patients and their cancers into estimated kind of like risk categories. And so the table on the right kind of helps show us, well, depending on, specific factors like the stage, like the GEP class, like specific mutations, whether it's SF3B1 or EIF1AX or BAP1. And then that can also help us understand what is likely to occur. And then also, how can we potentially intervene, especially in those people who were worried have a higher risk of recurrence. So this is a table to show kind of a summary of what has been done to this point in terms of trying to intervene at that point. So there are a lot of people who've thought about this question, right? Well, what can we do to try to reduce the risk of a recurrence at that time around the primary treatment? And so people over the years have proposed studies to say, well, okay, we have this medication, we have this intervention. What if we do it, for a period of time after the plaque? What if we deliver some sort of liver-directed therapy for a period of time after the plaque? Could that potentially reduce the development of recurrence down the line? A lot of these trials were what we call single arm trials. And what that means is they just said, okay, we're going to enroll a certain number of people on this trial. We're going to give them the intervention, and then we're going to see how it goes. But there's a major limitation to those single arm trials, which is that there's no comparison, right? And as we were mentioning before, a randomized trial is most powerful because then you can say, look, I gave an intervention to one group and I didn't to another, or I gave some other sort of intervention. And then this is what happened, and there's a strict comparison. When you do a single arm trial, you can sometimes have what we call confounding variables, or variables that are not measured that might have impacted how those people did. And it has nothing to do with the intervention you used. And so having said that, right, it's hard to do randomized trials. And as a patient, right, to enroll on a randomized trial is also, hey, I have, a chance of getting something I'm going to go through a trial but not get anything that might help me. That's also a more challenging proposition. And so one thing that we've done sometimes with these trials is we've tried to compare whatever the result was in our trial to something called a historical control. And the reason I bring that up is because you'll see actually in some of these clinical trials, that's what they did to try to say, okay, well, we can't do a randomized trial. That would require too many resources, too much money. It might be too much to ask, but maybe we can at least try to put our results in the context of what was happening before by using some sort of historical control. But still, there were some people who were able to do randomized trials. And going back, all the way to 1990, there were people who looked at something called BCG, which is an immune stimulant. It didn't really show the results that they were hoping for. There was another trial looking at chemotherapy delivered in different forms. Those also didn't really show the benefit that they were hoping for. This bottom trial in the top portion of the table is still ongoing work that's happening at Thomas Jefferson, Dr. Sidor, Dr. Asato, Dr. Orloff are all working on this trial. It's gone through a few different stages, but that's ongoing. They've seen some promising preliminary work that they're still assessing. And then the bottom portion shows all of these single arm trials, again, through the years that have been studied, ranging from intra-arterial therapies to immune stimulating therapies to targeted therapies. And by and large, unfortunately, to this point, we have not seen the results that we were hoping for, right? We have not seen that slam dunk improvement in terms of improving that risk of a recurrence. There's some signals here that are promising, but there's limitations, right? So this study looking at ipilimumab in 10 people, right? And so they saw some promising signals, but it's 10 people, right? And so it's very hard to say that might be generally applicable because there could be all kinds of variables that we're not capturing. And then just to highlight, not because it's me, but because I think some of the challenges that we have within this area is that sometimes we have an idea that should make sense, right? It's tested in the lab, it's tested in mice, biologically about what we know about this type of cancer. It should work, right? But then when we actually do it, we find that it's not effective. And this, is not just this disease. This happens across the board because human beings are very complex. And, the models that we have in the lab, sometimes they are applicable and sometimes they're not. In this trial, we gave crizotinib, which you guys have heard because of the darocrizotinib trial, where it seems like it is doing something in combination with the darovasertib. But in this trial where we gave crizotinib for a period of time after someone underwent their plaque or radiation therapy or surgery for up to a year, it did not seem to show any improvement compared to what we had seen in our historical data. And here we tried to, again, be a little bit innovative by using a database that had been developed by, at the time in Florida, Dr. Bill Harbour, and his group, the COOG, that had looked at, kept a database of how people had done before we had any of these types of therapies. And so we matched people based on their age, based on their tumor factors and things like that. And we said, okay, that seems to be a pretty equivalent group of people. Let's see how this stacks up. And there was basically no difference. And so again, that was a negative trial, but it's informed our decisions, our subsequent plans in terms of trying to figure out, well, what else could work? And so to highlight that, right, so some of the things that are happening now and some of the promising preliminary things that we're looking at, I want to start by talking about this trial, which is a phase 2 trial of adjuvant ipilimumab and nivolumab. Dr. Kennedy spoke about this combination this morning. When we use it in people with metastatic cancer, we do see that it helps a portion of people. It shrinks their tumor. It keeps things stable in another segment of people. It's not as effective as we would like it to be. And it's potentially associated with significant side effects. But the idea here was that, okay, well, maybe it's not as effective as we want when there's metastases, but maybe it could be more effective when there's still microscopic cells. They haven't widely, circulated or developed. And so this study was actually done through a cooperative group called the Hoosier Cancer Network, that allowed several institutions across the country to open and allow patients to access it. And what they did is they after someone had been diagnosed with quote unquote high risk melanoma, they gave them immunotherapy, the combination of these two immunotherapies, for up to a year, if they were able to tolerate it without any significant side effects. And basically, to summarize the results that were published last year at our major cancer conference, ASCO, Dr. Rapisuwan presented this as an oral presentation, was that at least compared to a historical control arm, again, using a very similar design to what we did in that crizotinib study, there seemed to be a significant difference in terms of that risk of a recurrence. Still not perfect, right? But compared to that historical control, there was that improvement. There are possibilities that this could be something that's, again, confounded by different things, but this is a promising signal that this could be more effective maybe earlier on. Now, I took this slide from his presentation because I think it also shows some of the limitations, right? As Dr. Kennedy was saying this morning, the rate of side effects can be high. And we saw that in this clinical trial. We saw that 48% of people had a grade 3 or higher side effect. And again, as I was talking about this morning, grade 3 and 4 side effects are considered more severe. 44% of people had to stop the treatment due to these side effects. Now, one thing that we don't know is, do you still benefit from the treatment even if you have to stop due to side effects? We have some early signals that that might be the case, but we don't take those side effects lightly because they can be significant, and most of them we can get immediate control of, but some of them can be chronic. And so we want to be very careful about exposing people to these risks, right? When we're weighing these risks and benefits, because there may be, right, a component of people here who are going to be fine no matter what. And so then we're exposing them to risk without any potential benefit. And that's one of the challenges of adjuvant treatment in general, is we don't know if some of these people may have been fine without any sort of treatment. So we want to have a high bar in terms of that risk and benefit calculation. But then the final point, and some of the research work that we're doing together as a group, is trying to figure out, well, who are the people who are more likely to have side effects, right? And maybe who are the people who are more likely to benefit as well? And is there any sort of association between the side effects and the benefit? And so that's how some of this incremental work happens, and that's still ongoing. And Dr. Rapisulan and us as a group are going to be hopefully opening up now a phase 3 trial based off of this. Well, it will be randomized to try to help answer this question more definitively. The second trial I want to talk about is this trial, the ATOM trial. And so we have folks from Immunocore here as well. This is a collaboration between, again, a cooperative group. And so this one is actually being run out of Europe primarily, but here in the US, we're actually going to be coordinating it. It's looking at now TEBI, right? So we talked about TEBI this morning. We've seen the potential benefit it can have in people with metastatic disease. And so we're now taking that same model, similar to Ipi/Nivo, and saying, well, what if we use it earlier after someone has had plaque or surgery, in the hopes that that can reduce the risk of a recurrence? And so this study has opened in Europe and is imminently going to be opening here in the US. There's a kind of final stages of planning right now. I've listed the sites that should have this trial open. It's going to be randomized, right? And so again, that's how we have to try to answer that question as best as possible. But it's going to give people the opportunity to receive 6 months of TEBI versus being observed. And then we're going to see, right? What impact does that have? And do people who receive that treatment for 6 months, is it worth getting it? Is it worth the side effects that they might develop? Hopefully the answer is yes. But that's the science that we're going to look at. We're also going to be doing some of those ctDNA correlates as well to see if what we found in the metastatic trial is also going to be the case here. And then this table is summarizing some of the other clinical trials that are happening in the space. So this top trial is in Europe. I'm actually not too familiar with it. I think it's in France, and the status of it I'm not 100% sure of, but they're looking at a vaccine. I mentioned the trial that's happening at Jefferson, where they're looking at these two different agents, sunitinib and valproic acid. They have different mechanisms, but they've seen some preliminary signals that it kind of met their cutoff for looking at it further, and so they're doing further research into that. The Ipi/Nivo study that I was just mentioning to you has kind of gotten that, shown those initial promising results, and we're going to be looking at it further. This trial, the IDEA folks are here as well. So, and Dr. Kennedy obviously went into detail regarding the darovasertib plus crizotinib data. So this is an interesting study that that's been designed looking at now what we call neoadjuvant therapy. And so I was mentioning that happens before someone undergoes their primary treatment. And so in this clinical trial, the idea is to give the daro upfront before the plaque, before the surgery, in the hopes that it does improve long-term outcomes, but also does it potentially improve local effects, right? Vision effects that people might have related to their radiotherapy. And so the hope is from both prongs that we're going to see benefit there. And that's currently in a kind of preliminary study, but we'll be enrolling in another phase 3 trial soon. And then there's also another TEBI trial that's happening that's looking at folks who their ctDNA has come back, but we don't see evidence of their cancer on scans. And the last one I want to mention is this trial of a drug called quizzinostat. And this is an interesting idea. It's being run out of the University of Miami. Dr. Jose Lutsky is leading that, again, from preclinical work done in Dr. Harber's group's lab, using these funding mechanisms to do that basic work to prove these ideas that might work then that we translate into human beings. Where this drug quizzinostat, what the objective of it is to try to re-regulate some of those genetic changes that occur in this disease. We know that because these chromosomal changes and things like that can occur, there can be kind of just disordered genetic regulation that's happening. And so this class of drugs tries to kind of reorder that disarray and make the cell behave more normally, right? To go from that bad behaving cancer cell into a more orderly, normal behaving cancer cell. And so that's based off of some really compelling preclinical work. And so now we're hoping that that will actually show improvement in people, which is our ultimate objective. And so that's going to be opening at a handful of sites around the country too, including at our site. And so that's just, again, kind of an encapsulation of where we are right now. I think the overall message is right. To this point, we have not seen the benefit we are hoping for, but there are trials happening right now, imminently opening, that we're really excited about, really hopeful for. And then other things that are coming down the pike also, whether they're immune therapies or targeted therapies or these epigenetic regulators that will hopefully also show that promise that we're all looking for. So I think I'll end there, and then happy to take any questions. Thank you.
All right, questions? I have one question, actually, maybe just to kick us off. In cutaneous melanoma with immunotherapy, they have always said that if you want to have a big immune response, right? And sometimes, even with patients we worked with, they have a big immune response. They end up even in the ICU, and then they have no evidence of disease. Like they have a complete response. So with some of these adverse events, for Uveal, like what is the thinking in terms of how a patient is responding and what that potential outcome could be?
Yeah, it's a great question. There's a lot of experiences out there like that, right? And I think Dr. Kennedy was describing a patient like that today too. I think any of us who use these treatments, we've all seen that, where someone might have a severe side effect, but it correlates with maybe like a very powerful effect against the cancer as well. There's been people who've looked at this. They've done a lot of kind of looking back at the data to see, okay, is there a correlation between side effect and response? And the best kind of information that I think we have is that having some sort of side effect might actually be a good indicator. We don't want people to generally have those severe side effects, right? Obviously, just for the person themselves to go through that, to have to go to the ICU, that means that something really serious is going on. And so we would love to avoid that. We do worry a little bit in people who have early severe side effects that require high doses of steroids, especially early on, that might associate with a dampening of the response. That's not a strong correlation right now. This is all preliminary work. But overall, it does seem that there may be an association between side effect and response. And I think we've seen that not just with combination ipi-nivo, we've seen that in other situations as well. Even with Tebi, actually, we've seen that people who have that rash that might occur or things like that, they may, again, loose correlation, they may have more likely benefit from the drug. So sometimes those negatives are not necessarily a negative, as long as we can make sure it's not too bad. Yeah.
Let's test.
This is perhaps a little bit off topic from what you've been talking about, but in other tumors, we have first-line therapy, second-line therapy, third-line therapy. So for metastatic we have Tebi as first-line therapy. What's your view of what's going to come in as the second-line therapy behind Tebi, or do we already have one, or where's the thinking on that?
Yeah, I mean, I think, there was a kind of algorithm that was shown before. I think we all, do something very similar to that right now, right? I think most of the time it depends on what someone's HLA type is, right? And so if you have the AO201 type, then TEBI is going to be the front line in the vast majority of cases. And then depending on potential, kind of characteristics of where the cancer might be, things like that, then the liver-directed therapy, the immunotherapy, the ipi-nivo combination. Hopefully, as we get, approval of other agents, those will also come into play for HLA positive patients. If you're HLA negative, then, TEBI goes away, right? And then it goes immediately to those other interventions, whether it's ipi-nivo, whether it's liver-directed therapy, and hopefully as we get approval of other agents, those might be incorporated immediately as well. And of course, during this period, regardless of the HLA positivity, if there is a rational and clinical trial that we think is promising, that we think is appropriate, in a situation like this, right, where we don't have a dozen medications to choose from, that's always an appropriate choice. That requires commitment, right? That requires clinical trials have to follow specific instructions. We have to be strict with them because that the data relies on that. But if it's at all possible, that's something we always encourage as well. And that will continue to be the case, I think.
Question. It seems like 3 years is a number. I don't know, does the FDA require that for clinical trials and that's their standard? Or, I mean, what's the time frame around looking at results? Do you continue to go out 5 years, 10 years to watch, what happens over time, even if a treatment is approved? And then are there times when you stop it after 3 months because you see bad results or whatever? Like, what's your experience on that?
Great questions. I mean, I think, and when we look at how much a medicine or an intervention might or might not benefit, we want to see those long-term, right, durable benefits. And in skin melanoma, right, we've seen that, right? We're doing now the long-term analyses. We're getting the 5-year analyses of these trials. But obviously then that takes longer to show the results. And so, as we think about this and hopefully as we see treatments that are going to be effective, we're going to sometimes have to use kind of time points that may be somewhat arbitrary in a sense, right? Like, okay, at 1 year, we're going to report the outcomes, at 2 years, at 3 years. But the hope is always that those benefits will persist and continue to go on longer. And in general, we're going to continue to do that tracking.
For the immunotherapy drugs, I think I've heard doctors say that sooner or later they kind of run their course and the cancer cells become more potent than your immune system at some point. The ones that have survived that long take over. Is there any, if you have multiple doses, right? If in your case, adjuvant therapy, you're talking about, if you did it for some period of time, say 2 years or 3 years, whatever it is, nothing shows up, but then later cancer shows up, is applying the immunotherapy again have value, or does it is it diminishing?
It's an amazing question, and I think something we grapple with, right? Because we don't know, right? And so we do have a little bit of a corollary in skin and cutaneous melanoma, right? Where it's now FDA approved, a standard thing to do for someone who has a certain risk skin melanoma. You get up to 1 year of immunotherapy, and then we enter surveillance. And some people still have a recurrence, right? There's research that's been done saying, well, okay, is immunotherapy no longer effective at that point if it comes back? Does the fact that it came back mean that the immunotherapy didn't work, or did it work temporarily and then the cancer cells found a way around it? These are unanswered questions, right? These are things that we're still trying to figure out. There are some loose kind of associations that we think that, the longer the time was that the person was free of their recurrence, the time since they received the immunotherapy, it's more likely that re-challenging with the immunotherapy is going to be beneficial. And maybe that, just kind of logically makes sense that means that maybe it did something for a period of time. Melanoma and melanocytes have also just like a unique cell and a unique kind of biology in their behavior, where we've historically even seen that people had a skin melanoma that was removed, and then 20 years later, something pops up, right? Why did that happen? Why did a cell sit around for 20 years and then grow? That's kind of weird. But there's this complex interaction of things that's happening within the cell and then within the environment in which it's sitting in and existing that dictates that. And thankfully, we have amazingly brilliant people who are working on these exact things. One of the grants that Kylie was just highlighting at Dana-Farber, they're looking at these exact mechanisms, right? And so I think it's a great question. We don't know for sure. We do think that some people will still benefit from getting more immunotherapy, potentially intensification of that immunotherapy, using 2 drugs instead of 1, or a different set of immune stimulating medications. But yeah, still stuff we have to answer.